Okay, hi, this is Elliot Fishman, and this is CTisus Live. It's the 2nd of January. Some of you are still on vacation, and some of you are at work, like me, working away, trying to catch up. So whether you're home or away or in your office or goofing around, best wishes again for a happy and healthy new year. And for a topic, I chose the radiologist shortage. And the reason I chose that topic is every place I go, everybody you speak to, that's the number one topic. Now, before you make the assumption that I have a solution, let me tell you that I have no solution. Times always change, right? Life is a cycle. I remember Ron Evans, who was very famous, the head of the Mallinckrodt Institute, gave the opening address in RSNA 25 or 30 years ago. And things were tough at that time. I remember those were the times when fellows had difficulty getting good jobs or any jobs sometimes. And at RSNA, he said, look left, look right. Within 3 years, one of you is going to be out of a job. Well, Ron Evans was very smart, but wasn't that smart. Obviously, got it totally wrong. There were macro reasons he got it wrong. We know that imaging has become the physical exam. Imaging is critical in the ER. It's critical in oncology. It's critical in the acute setting as populations get older, as the population increases. Imaging, whether it's CT or MR, ultrasound, plain films, fluoro, maybe not fluoro, breast imaging, all of these things are increasing. With the push for screening, it's even going to become more so. I was in a meeting recently, and everybody is short people. Half the people are using people who are remote. Some places have hundreds of remote radiologists. You can work by the hour, by the case, by the day, by the week, whatever you want to do, because some people are backed up thousands of cases. They can't get the studies read. And the other people who are keeping it together are barely keeping it together, and people are being worn out, and there's no end in sight. If you think about it, what can you do? We can say, well, okay, we'll limit use of imaging. That's not going to happen because we need imaging. Imaging is great. We can have AI, and AI may help us, and I think it will. We've spoken about that. But at this point, AI is a helper, and so it may help you get through the cases faster or more accurately, but it's not going to really do anything at this point to say, oh, we need less radiologists. Though places like Europe, where they had 2 readers for mammography, now have 1 reader in AI. So in that sense, it does help with the shortage, right? You get rid of 1 radiologist. But I think in the future, particularly things like low revenue things like plain films will be read by the computer unless they're positive, and then the computer will kick it over to the radiologist to give a second look. Though things like DeepMind from Google can read the normals as well as the abnormals, but I think what will happen with the abnormals is somebody will give it a second read. But that's not happening today. And again, AI will be helpful, will increase our accuracy, hopefully miss less pancreatic cancers, detect disease earlier, but it's a helper. It's not a replacement for radiology. People are using super techs. Browen Jones, may she rest in peace, would turn over if she knew we were having techs do the swallowing studies with radiologist supervision. Truth is, radiologists don't know how to do fluoro anymore. Not to date myself, but I probably did more fluoro in a day in my residency than a resident will do now in 4 years of residency. So people don't have the interest and surely don't have the experience. Fortunately, we've got rid of most of fluoro, but not all of it. So it still needs to be done. And giving it to senior radiologists is not going to help because there are no senior radiologists left. Now, people are doing all sorts of things. Yes, they have retired partners and have them read a little bit, whatever they can do to help. That's great, but usually the reason people stop reading is they've been bored or tired or they've had enough. And so relying on people who are retired to read, and you see articles about that, is unlikely to make any difference because there was a reason they retired. It wasn't like they were laid off or fired or whatever. Some groups maybe have some age cutoff, but most people retired on their own. And yes, some may want to come back and do a little bit here and there. But for those people, it's coming in and schmoozing with people that they like, and everything is remote. So, if you invested wisely and you have good income, you don't need to work. And so most people choose not to work. That's why people retire. They don't want to work anymore. Now, what can we do? Well, you can train more residents. That's always a solution. But you need the government to support more residents. And every specialty is asking for more residents, so that's not likely. And if you do it, you then need to take residents, train them for 4 years or 5 years. So it's not a short-term solution. We can make it easy for foreign radiologists to come here. Again, the challenge of, we work with a lot of very smart people across the world, but people aren't rushing to come to the US. There's demand for radiologists in any country, whether it's Israel, France, England, Turkey, Netherlands, you name it, Brazil. So it's not like people have oversupplies. And then, of course, if you're taking people from countries where you're really not aware of their training, it's hard to really judge what you're getting into. There are a lot of smart people, but how do we know who's smart and who's not? It's not that easy to do. It's not like you can do a multiple choice test and come up with the answer. So it does become a little bit challenging in that regard. But making it easy for qualified foreign radiologists to come to the US may be one short-term solution. Now, will that happen? Well, I guess, a lot of the issues, of course, relate to the new president. And, there's a lot of discussion about H-1Bs where Musk is for it, Trump may be for it. So maybe there'll be a possibility, but you never know. It takes some Congress to go along with many of these things as well. So it really is a challenge in that regard. How do we do things? What else can you do? I don't know. I think the challenge, of course, is that people can't work harder. People don't want to work more. People, particularly in private practice, are getting paid very well. The other thing is, as people work more in academics, they're teaching less. And you have a lot of remote people in academics, not that they're not qualified, but remote, you're not involved day to day in resident teaching, or the academics are writing articles or doing all those other things you do in academics. You could see the number of articles being submitted for publication is decreasing. It's hard to cover the multidisciplinary conferences. It's hard to cover just the resident conferences, because if you have people who are remote who really aren't that interested in doing teaching, it's not going to happen. You can be an excellent radiologist to read the films. It doesn't mean you want to prepare lectures or give conferences. And again, the reward is you're being paid by RVUs. Articles in journals like JCAT have shown, or JACR, about the disagreements about multidisciplinary conference. Should you be doing it? It costs time and effort. You're spending hours, but you get no reimbursement. In fact, you lose money because the time you do the conference, and I love those conferences, you're not reading. And if you're not reading, you're not getting RVUs. So how do you change the reimbursement thing? An excellent question. I think private practice is being challenged just by the sheer volumes, but I think academics is being challenged by the volumes, the danger and lack of teaching, and the danger of not doing academic work. The reason you go to academics is not to make money, but it's to do the teaching and to do the academic environment. If you don't have time to do academics, you're not going to stay in academics. So it's really a problem, and everybody is complaining about it. Even places like Shock Trauma, University of Maryland, they don't have a radiologist all the time at night. Remember Stu Mervis and His colleagues made University of Maryland shock trauma a beacon around the country for emergency radiology, and they can't even staff it now. I've been told in some institutions now, if you work the overnight ER shift, you only have to work 1 out of 4 weeks and you get paid even more. So wow, that's a pretty good deal. You can work 2 jobs, work 2 out of 4 and make, $1.5 million a year. So a lot of things like that. It's really a very difficult time. And I don't think looking left and looking right is going to help you, because there's nobody to the left of you and there's nobody to the right of you. There just aren't enough people reading films. And again, I don't have an answer. We need to hope AI can provide some answers. Perhaps the government through HB1s, perhaps putting more people in training. Yes, that'll take time, but if you don't get started, you're not going to get finished. People have talked about, do you need to have 4 years of medical school? Maybe it should be 3. Then you can increase the numbers and get people into their specialties earlier. That's a possibility. But I think doing nothing, which is what we're doing now, is really not going to work. I think it's an interesting challenge. I think it's not just radiology, it's surgery, it's medicine. Every field is short-staffed. People want to separate life and work. That wasn't the thing in the past. Everybody worked till the films were read. Now you work your shift, you read a lot, but you're not going to work just to work. Those days are over. So it's an interesting problem. If you have any thoughts, solutions, tell me what you're doing. Put it on our comments page. And with that, I'll thank everybody and have a great day.